Hello everyone, welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki and I'm one of the guys behind Noble Psychiatry and Noble Pathway, and I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that not only affect their mental health, but their families, relationships, and the quality of life. That is why this conversation is important. Today, we'll explore post-traumatic stress disorder, PTSD, in a practical, evidence-based, and clinical relevant way aimed at improving patient care and strengthening our approach as mental health professionals. Thank you for being here, and we will get started. This presentation is produced and designed by Noble Psychiatric Services. This lecture introduces PTSD through a clinical and evidence-based lens. Anyone listening to this lecture will define trauma and diagnostic framework established by the DSM-5 with the emphasis exposure to actual or threatened death, serious injury, or sexual violence. Understanding the neurobiology of PTSD helps contextualize symptoms within disrupted stress circuits and neurochemical imbalances. Anyone listening to this or the trainees will also explore the diagnostic complexities that differentiate PTSD with related conditions such as depression and anxiety disorders. Emphasis will be placed on both first-line psychotherapies and pharmacological strategies, including the role of SSRIs and SNRIs. Finally, the session will address common comorbidities such as substance use and chronic pain, as well as long-term management strategies to prevent relapse and chronic disability. Epidemiology and the impact. About 6 to 8% of the US population has developed PTSD, but the problem is such prevalence among veterans, women, and people who have experienced interpersonal traumas. Women have been disadvantaged because they are more exposed to sexual assault and gender-based violence. PTSD is usually associated with significant occupational disability, social isolation, and a broken family system. The hyperarousal and avoidance habitual patterns are chronic and disrupting work and relationships and comorbid physical health issues, including cardiovascular disease, and are also abundant. Stigma or misdiagnosis is a factor which makes many patients procrastinate when it comes to the treatment. The morbidity in psychiatry and the rise of the risk of suicide presented by the disorder are rather significant worldwide, which means military and civilians setting needs trauma-informed care and prevention against early signs and symptoms of this disorder. As far as the etiology and the risk factor, PTSD is a resultant of interaction between traumatic exposure, biological susceptibility, and post-event psychosocial situations. Extreme or social trauma such as sexual violence or war put these people at more risk. Gene organic or gene influence include polymorphism in serotonin transporters are capable of increasing also the vulnerability. Adversities in early stages of life, neglect, and insecure attachment increases sensitivity to stress. Events such as social isolation, lack of effective coping mechanism, and being constantly threatened aggravate the condition following the trauma. On the other hand, protective factors denote resilience, good connection with family, and reaching trauma-oriented therapies. Clinicians can use the understanding of such interaction to focus more on the prevention and early intervention measures, especially when dealing with vulnerable groups like the refugees or the first responders. The neurobiology of PTSD, manifestation of the dysregulation in the hypothalamic pituitary adrenal HPA axis in the response to stress. Excessive chronic stress causes an abnormal pattern of cortisol and corticotrophin release hormone. Neuroimaging always displays hyperactivity of the amygdala, which contribute to the exaggeration of the fear response, and the hypoactivity of the prefrontal cortex that fails in regulation of emotional memories. The decreased hippocampal volume is associated with the problems in defining the fear and distinguishing the dangerous and the safe stimuli. Hyperarousal and intrusive recollection is caused by neurochemical imbalances, especially in the increase of the norepinephrine and glutamatergic activity. Such results consolidate the biological validity of PTSD and justify specific pharmacotherapies that will help control the state of stress and fear. As far as the DSM-5, it defined PTSD as a trauma and stresses-related disorder requiring prior exposure to traumatic event. Criteria 1 defines what is meant by direct exposure, witnessing, or learning about the trauma. Criteria B, the presence of intrusion symptoms, which are distressing memories or dreams that are persistent and which demonstrate uncontrollable re-experiencing. Criterion C is also associated with the avoidance of either internal or external cues associated with the trauma, which make the mechanism to sustain the disorder as it does not allow for the emotional processing to take place. These criteria are used to stress that PTSD is not merely a recollection of the trauma, but instead a dysregulation of the fear memory system and interferes with the normal functioning as well as social interaction. We keep going. Criteria D, it captures the negative shifts in mood and cognition such as guilt, self-blame, or detachment, while criterion E includes hypervigilance, irritability, and exaggerated startled response. The symptoms have to have at least be there for 1 month, and the patient has to be clinically significantly distressed and impairment in order to satisfy the diagnosis. The distinction between PTSD and acute stress disorder is dependent on the duration of the symptoms. Cultural manifestation of trauma should also be taken into consideration by the clinician, and the diagnostic confirmation is to be carried out with the help of a structured instrument, including some of the screening tools like the clinician administered PTSD scale CAPS-5. There's also PCL-5 that can be also be utilized. Adequate diagnosis can lead to timely treatment, and this minimizes chronic costs. As far as the clinical presentation of PTSD is heterogeneous, but generally consists of re-experiencing, avoidance, and negative mood and hyperarousal. Nightmare, flashbacks, and a lack of trust in other people can be reported by the patient. There is a differentiation, or there's a difference between men and women. Often, men are characterized by externalizing behaviors, and women tend to display internalizing symptoms such as guilt or withdrawing. Distress expression and disclosure of the trauma is influenced by the cultural beliefs at times. Functional consequences may also be serious, which affect the working life, physical condition, and the sex life. Clinicians need the ability to determine the severity of the symptom, comorbidities, and coping methods in order to approve the plans accordingly. As far as the differential diagnosis, the symptoms of PTSD are similar in few psychiatric disorders. This leaves a close need to make a distinction as far as the diagnosis. Depression has a lot of common things in relation to PTSD, for example, anhedonia and guilt, and general anxiety is characterized by constitutional worry as opposed to fear associated with the traumas. Panic attack could be experienced. However, the most notable feature of PTSD is the traumatic triggers. TBI may be similar to PTSD with regards to irritability and the lack of concentration. Neuroimaging and the history can be made to distinguish the two. Dissociative disorders are characterized by depersonalization, which is related to the trauma. Drug use frequently becomes a maladaptive coping level, and it needs to be screened much more better. Proper differential diagnosis will lead to the correct choice of treatment and prevent a way out for the patient and the clinician. As far as the comorbidities, PTSD is accompanied by comorbid physical and medical conditions, which is very common and is likely lead to a poor outcome. The rate of the comorbidity of depression and anxiety is high as 50%, and the risk of substance use is widespread because of the attempt to self-medicate. Systemic effect of persistent involvement of stress response include cardiovascular and metabolic diseases, which associated the psychological trauma with the decrease in the physical health. There should be constant evaluation and crisis planning on suicidality. Multidisciplinary care is best prognosed through integration care. This is achieved by treating the psychological and somatic symptoms. The multidisciplinary teamwork, psychiatry, primary care, social care are essential in total management. When it comes to the psychotherapy, it remains the cornerstone of PTSD. Cognitive processing therapy as CPT and prolonged exposure PE are trauma-focused therapies that enable maladaptive beliefs to be characterized as traumatic memories and refreeze cognition. The eye movement desensitization and reprocessing EMDR incorporates bilateral stimulation in facilitating the integration of adaptive memories. The acceptance commitment therapy, ACT, and narrative exposure therapy have potentially, particularly in complicated trauma and standing refugee population. An effective treatment must involve trust families with secure therapeutic relationship and cultural awareness. Pharmacotherapy and psychotherapy can be used in combination to improve the risk, the results, and decrease the risk of reoccurrence. More on the treatment, pharmacotherapy is used as either a primary or adjunctive treatment. The first line medication, including sertraline, Paxil, which is a common medication, and sertraline, as well as SNRI like venlafaxine, which are also backed by strong clinical trials. These agents regulate the transmission of serotonergic and noradrenergic, which helps intrusive thoughts and mood instability. Prazosin is also good in terms of treating nightmares associated with trauma by lowering the central adrenergic activity, and characteristic antipsychotics can also be applied to assist in severe hyperarousal or even psychotic traits, but they ought to be applied very carefully when you use them. The use of benzos is contraindicated because it has a possibility of dependency and it can cause fear extinction. The psychotherapeutic and psychosocial intervention should always be used with medication to achieve the optimal outcome. As far as complex PTSD is a condition that comes as an outcome of persistent trauma, which may start in childhood and cause some disturbance to the connection. These patients experience increased emotion, distress, interpersonal distress, and somatic distress. Veterans, refugees, and emergency workers are the population that can be exposed to repeated traumatic events and cumulative stress. Traumatic-informed care focuses on the safety, empowerment, and collaborative. Clinicians should use cultural competency to understand various trauma stories and mental illnesses stigma. Combining evidence-based therapies and pharmacology with social support have the most positive recovery effects. And that concludes this presentation. Hopefully you were able to learn something. If you have any questions or concerns or want to ask any further questions, feel free to send us an email or feel free to also make a comment. With that, from Noble Psychiatric Services, we want to thank you for taking time to listen to us, and we wish you nothing but the best.